So this is part two of week five's psychotropic medications lecture. I had finished off on slide 42, talking about the nursing process for mood stabilizers. This is slide 43. So the next category we're going to be learning about is antipsychotic medications. So we'll talk about psychosis in more detail in a few weeks, but for now, we need to know that psychosis is when the client loses touch with reality. So they might experience some of the symptoms that we previously learned about, such as hallucinations or delusions. They can even have disorganized thought content and so on and so forth. So antipsychotic drugs are then used to treat this serious mental illness. So they can be used for drug-induced psychoses, schizophrenia. You can also use antipsychotic medications for the treatment in autism. We can also use antipsychotics for treating extreme mania. So as I previously mentioned, with lithium, it can take 10 to 21 days for the onset of action for lithium. So during that time, until the lithium reaches that therapeutic level, we can also give antipsychotic medications to help with the extreme mania that the clients are experiencing. We can use this for personality disorders, which we'll also be learning about in the course, as well as treatment-resistant depression. So the way that antipsychotics usually work is that they block dopamine receptors in the brain, and this is going to result in dopamine levels in the CNS that are going to then decrease. And this is going to result in a tranquilizing effect for clients that are experiencing psychosis. So it's important to know that antipsychotic medications don't cure psychosis, but instead they're chemically controlling the symptoms that the client is experiencing. And there are first generation or conventional or typical antipsychotics, and then there are the second generation or the atypical antipsychotics. So the first generation, also known as the conventional or typical antipsychotics, these were originally developed in the 1950s. And the theory is that when it comes to schizophrenia, which is one of the conditions where the client can experience psychosis, where they lose touch with reality, there is a theory that when there is an overactivity in dopamine, this is what can result in the positive symptoms of schizophrenia. So the positive symptoms in schizophrenia, this involves an excess or a distortion of normal experiences. So when we're thinking about the positive symptoms, we're thinking about hallucinations, delusions, even the client experiencing disorganized thought, disorganized speech. In contrast, we have the negative symptoms of schizophrenia. So these are the ones that are more challenging to treat. So here we see a reduction or an absence of normal functions. So here we're looking at the flat emotional expression, the reduced speech or poverty of speech, the lack of motivation, the social withdrawal, the apathy, the catatonia, like the slow movements, the reduction in the body's movements. So all antipsychotics do show efficacy in improving the positive symptoms. It's the negative symptoms that are more challenging to treat. And typically, the first generation drugs are less effective in managing the negative symptoms. And the atypical antipsychotics, so this is the second generation, they actually show greater efficacy in treating both the positive and the negative symptoms. So here are just some examples of some first generation antipsychotics. So we have haloperidol, which I forgot to write in brackets, is also known as Haldol. There's also chlorpromazine as well as loxapine. So with the first generation antipsychotics, they do have significant adverse effects. So the client can experience weight gain, as well as insulin resistance. There are changes in their serum lipid levels. They might even experience cardiometabolic syndrome, which is where they have visceral obesity, increased blood pressure, an increase in their fasting plasma glucose levels, and a high density cholesterol level as well. And of course, the blurred vision, the dry mouth, and the urinary retention, which are those anticholinergic effects that we've previously learned about as well. So the next few things that we're going to chat about are important to know when it comes to antipsychotic medications and their adverse effects. So the first is the extrapyramidal symptoms, also known as EPS. So these are a movement-related side effect that can be caused by medications, primarily by antipsychotics. So previously, when we were talking about the effects of dopamine, we had mentioned how it plays a role with our mood and our motivation and our reward system. I had also mentioned that dopamine also controls our smooth, coordinated muscle movement. So typically, with first generation antipsychotics, they block the dopamine receptors. So when the dopamine receptors are blocked, there is going to be a decrease in the dopamine activity. So then this is going to result in the movement control this is going to result in a disruption in the movement control of our body. And this is where the EPS, or the extrapyramidal symptoms, occur. So because of this, the client might experience involuntary muscle symptoms that are similar to those of Parkinson's disease. So the client might experience akathisia. So this is the distressing muscle restlessness. So here, the client might feel this constant sensation of unease. They feel restless, and they might even have these repetitive movements like pacing or rocking. The client can also experience akinesia. So here we have this lack or this loss of voluntary movement. So this could be manifested as a delay in initiating movement, or they might freeze in the middle of a movement action, or their movements are too small to actually be seen. The client might also experience dyskinesia. So these are movements that are involuntary and repetitive. So this can involve movements of the face, the mouth, or even their limbs. So you might see some repetitive facial twitching, some tongue movements, some lip smacking, or even some jerky limb movements. There's acute dystonia, which are these painful muscle spasms. So for our nursing assessment, we do have to be aware that with first generation antipsychotic medications, the client might experience EPS. So we have to monitor the client, right? We have to even teach the client about EPS and what to look out for so that they can also inform their healthcare team. And if we do notice that the client is beginning to develop the initial signs of EPS, that's something that we do have to continue to monitor. So typically, if a client is prescribed an antipsychotic, they are also prescribed benzotropine, also known as cogentin. So usually when I've worked with psychiatrists, they prescribe it. We don't wait until the client develops EPS. We just start the client on antipsychotics and also start them on benztropine or cogentin so that it helps with the EPS symptoms that they might develop. The next thing that we need to be aware of with antipsychotics is NMS, also known as neuroleptic malignant syndrome. So this is a rare but serious reaction that can happen to certain medications, primarily from antipsychotics. And essentially it happens when the body loses control over temperature and muscle function. So this is a medical emergency, and it happens when there's a sudden drop in dopamine activity in the brain, or if we abruptly stop taking medications where dopamine is heavily involved, such as antipsychotics. So here we might see an extremely high fever. We might see unstable blood pressure, an altered mental status, and even muscle rigidity. So although this is a medical emergency, if there is quick treatment, people do recover. So also we have to be aware of this as nurses, teach our clients about what the signs and symptoms look like so that we can catch it early. And typically with the management of this, we have to stop the medication that is causing NMS. There's also supportive care, right? So providing hydration, IV fluids, cooling the client if they have this high fever, and monitoring them as well. Medications like muscle relaxants can also be given, especially because they have that muscle rigidity. The next thing that we do have to be aware of when it comes to antipsychotic adverse effects is tardive dyskinesia. So previously I did mention that dyskinesia it involves those involuntary repetitive movements. So tardive means late. So usually tardive dyskinesia is associated with long-term antipsychotic therapy. And this is the same thing as I previously mentioned. It's those involuntary contractions, those movements of the oral and the facial muscles, right? So you might see the grimacing, their tongue sticking out, or their lips smacking, or like other facial twitches or jerky limb movements as well. And also this term is coming up again, the choreoathetosis, so the wave-like movements of their extremities. So early detection is key. However, because this is tardive dyskinesia, this is that late type of dyskinesia, because it's associated with the long-term antipsychotic therapy, it can sometimes be permanent as well. So for that reason, we have to be continuously monitoring our clients and assessing them for the early signs of dyskinesia. So next we have the second generation antipsychotics, also known as the atypical. And these were introduced in the 1990s. And they have fewer EPS, so extrapyramidal symptoms. And the benefit of the second generation is that they actually target both the negative and the positive symptoms of schizophrenia. So now, and the second generation antipsychotics are chosen as the first line of treatment for psychosis and schizophrenia because of their ability to produce fewer EPS. And they do have dopamine and serotonin blocking effects. So, because serotonin is also involved, this interaction appears to alleviate the negative symptoms associated with schizophrenia, as well as the cognitive and the memory effects associated with schizophrenia. And this is just a list of some of the second generation antipsychotics we might see. So we have clozapine, also known as Clozaril, risperidone. This can also be given as a pill or an injection. We have Seroquel, which is also quetiapine, olanzapine, Invega and Invega Sustenna. This is also given as an injection, as an injectable form as well. Of course, there are also adverse effects when it comes to atypical antipsychotics. So the client might be experiencing metabolic syndrome. So they have increased weight, elevated blood glucose, elevated levels of triglycerides. And because of the increased weight, they might also experience insulin resistance. The client also still has the potential to develop EPS and NMS. It's just less than the first generation antipsychotics, but the potential is still there. So we still do have to monitor the client for EPS and NMS. So I wanted to specifically talk about clozapine. This is a second generation antipsychotic, and it's actually the first of the second generation antipsychotic drugs to be developed. And it is relatively free of the extrapyramidal motor disturbances of the other antipsychotic medications. And it is thought that clozapine it blocks the dopamine receptors in the mesolimbic system, which is different from the dopamine that's blocked from the other antipsychotics. So because it works on a different part of the brain, this is one of the reasons why it actually exerts a minimal EPS effect. So there are other adverse effects that are associated with clozapine. So typically clozapine is used for treatment-resistant schizophrenia, and it does show to work very well with treatment-resistant schizophrenia. But the major effects are the adverse effects rather are the potential for bone marrow suppression and a granulocytosis. So this is a severe and potentially life-threatening condition where we have extremely low levels of granulocytes, which is a specific type of white blood cell that fights off infection. So for this reason, when a client is on clozapine, we have to monitor their blood work extensively. So specifically, we are monitoring their ANC, which is their absolute neutrophil count. And if a client does not do their blood work, they're not going to get their medication. So here I have in quotes the no blood, no drug. When a client first starts on clozapine, for the first 6 months, technically it's the first 26 weeks, but it's the first 6 months, They have to get blood work every week. After that, the next 6 months, they get blood work every 2 weeks. And then it's monthly for the duration of the time that they are on clozapine, which could be lifelong. So, as I mentioned, no blood, no drug. So typically, in Ontario, and I'm sure there's different portals across Canada, but I'm just speaking specifically about Ontario. There is a Closeral support network. It's a portal, and if you are a nurse that is monitoring a client's clozapine levels, the blood work results need to be sent to the Closeral portal. They also need to be sent to the pharmacy that is dispensing the clozapine, as well as the nurse and the physician or the psychiatrist that is reviewing the blood work. So all of these parties involved have to get the weekly results for the first 6 months and the bi-weekly results for the next 6 months, and then monthly thereafter. And once the pharmacy reviews the results, only then will they dispense the next, week's worth of clozapine. And if the client is on biweekly, then blood work, then they'll get the biweekly dosage. But until all of the parties have reviewed the blood work, the pharmacy is not going to dispense the medications, because if the A and C levels are dangerously low and we give them clozapine, that can result in a serious life-threatening condition for the client. So for the purpose of this course, you don't need to know the levels, and even with the Closeral portal, they do have like a yellow flag and a red alert flag, and then the parameters for when you get the blood work changes based on what levels your ANC blood work is in. But knowing that the Closeral portal, the pharmacy, and the physician and the nurse all have to be given their blood work results, that's important, because this is the only antipsychotic that we do this for. So if the client does start to have low ANC levels, we do have to monitor for flu-like symptoms or other, signs and symptoms of infection that could happen because of the low ANC. And like I said, the blood work parameters and the dosing, all of that can change depending on, how low it goes. But for the purpose of this course, we don't need to get into that. There are other second generation medications that are also used for psychosis. So we do have Abilify, which is also available in oral and injectable form. There's also Latuda, which is an oral medication. It's not available as an injection. Same thing with Sapphirus. It's oral only, not an IM. So when it comes to the nursing process for antipsychotic medications, of course, we have to assess the client's psychotic symptoms, right? What type of symptoms are they experiencing? Is it positive symptoms, so hallucinations, delusions? Is it the negative symptoms, the flat affect, the poverty of speech, the apathy? We have to do baseline vitals, their weight, blood pressure, lipids, right? Even in ECG, because as we mentioned, these all can get impacted with the use of antipsychotics. Is there a history of EPS or even metabolic syndrome? Maybe they were using other medications previously. So definitely getting that history. In terms of diagnosis, which I realized I forgot to write here, is there a risk for metabolic imbalance, because of the antipsychotic medications that we're using? Is this related to weight gain or diabetes or even dyslipidemia? Or does the client, is the client at risk for disturbed thought processes related to psychosis? The planning, the client will exhibit reduced psychotic symptoms. The client will maintain adequate functioning with minimal adverse effects. For our interventions, as mentioned, we are, of course, monitoring for EPS, right, as well as tardive dyskinesia. For the atypicals, we're monitoring for metabolic syndrome. For the first generations, we're monitoring for NMS. But still, anytime a client is on antipsychotic medications, you should still be monitoring for EPS, tardive dyskinesia, and NMS, because even though the atypical antipsychotics have a lower chance, lower risk of these, they can still develop EPS, NMS, and tardive dyskinesia. So it should still be part of your assessment and your ongoing monitoring. Of course, we're providing teaching to the client on adherence and avoiding alcohol and regular follow-up, especially if they're on clozapine. You have to go for your blood work, right? So this is a conversation that the psychiatrist typically has with the client to ensure that they're going to be compliant with the blood work. Because if the client is not going to follow through with the blood work, then they're not going to be a good candidate, since no blood, no drug. In terms of our evaluation, we want to see, is there a reduction in the positive or negative symptoms, such as the hallucinations, the delusions? Is the client able to tolerate the medication with manageable adverse effects? And of course, hopefully there is no evidence of EPS, NMS, or metabolic syndrome, but if there is, we need to be evaluating that as well. Lastly, I did want to mention that sometimes clients do want to use some natural products, herbal medications, some vitamins, homeopathic, Ayurvedic, some other medications for their mental health conditions. And this can be something that we see that might result in some major concerns. So this has to be part of our assessment. This has to be part of our health teaching, that the client needs to be transparent with their team about all of the natural products, all the supplements, vitamins, over-the-counter medications that they might be using, because there can be a potential long-term effect. Some of these natural products do interact with psychotropic medications. They could cause long-term, kidney damage, liver damage, nerve damage. There's even the possibility of adverse chemical reactions. Are the clients using other substances? Are they using, other conventional medications with their psychotropic medications? So we have to have full transparency, and that the psychiatrist or the physician NP in charge, they have to know about all of the natural herbal products that the client is using, so that we can continue to monitor and ensure that there is a safe compatibility between the psychotropic medications and the natural products. So thank you so much for listening. This is the end of the lecture.